Hello, everybody. Welcome to the Depression Series Virtual Education Summit presented by the Johns Hopkins University School of Medicine at Psychiatry Care Live. My name is Glenn Treisman. You are tuned into a live session called New Insights into the Neurobiology of Depression with Dr. Adam Kaplan. Before we get started, I would like to remind our audience that we're taking questions in real time throughout the presentation. You can send me your questions, which I'll pick up on this computer anytime during the program through the box in the lower left-hand side of your screen. Dr. Kaplan is an assistant professor of psychiatry and neurology at Johns Hopkins University School of Medicine. He is also the chief psychiatric consultant to the multiple sclerosis and transverse myelitis centers here at Hopkins. And he did his training here with Saul Snyder and is a distinguished young scientist as well as clinician, and one of the people who I most enjoy interacting with here at Johns Hopkins. He is a real expert on depression and the neurobiology of depression. Dr. Kaplan, welcome. Thank you so much for coming.
Thank you, Dr. Treisman. It's my pleasure to be here. So I thought to sort of get the conversation rolling, we would start with a review of what we know. So there are certain sets of studies that have been repeated in this country and other countries for the past 50 years. And I thought just to give us a solid ground on which to discuss the current neurobiology of depression, I'd start off with just some of the highlights of some of the things we know. So to begin with, I thought I would just touch on three different studies that relate to our understanding of the neurobiology of depression. And again, once we do this, I thought we'd have a more general discussion about what is going on currently, what we know currently about some of the different models to understand the neurobiology of depression, and then we can end with some discussions of where the future directions are going. Does that sound reasonable?
Sounds great.
Okay, super. So to begin with, we have known for decades now that essentially people who are depressed oversecrete the stress hormone in the brain, which is cortisol, or the stress hormone that has an effect on the brain, which is cortisol. And this is controlled by the hypothalamus, releasing corticotropin releasing factor into the pituitary, which releases ACTH, which then causes the adrenal glands to release cortisol. Cortisol is the stress hormone of the body. It also ends up being the brakes of the immune system, but I think we'll come back to that later. It's interesting that the same molecule. But what's been known for decades now is that patients who are depressed oversecrete cortisol. So they're in a chronic state of stress, essentially, and that's not a surprise given everybody who's participating in this knows that depression is an incredibly stressful experience, and we can talk a little bit later about how this might play an important role into the close communication between depression and autoimmune diseases. But in any case, because people's cortisol varies at different levels, what people now have learned is that if you give dexamethasone, which is a steroid, it should suppress the secretion of cortisol. So if you give dexamethasone at 11 o'clock at night, and then in the morning you measure the cortisol levels, they should be suppressed. Morning cortisol should be relatively high, but you've suppressed it with dexamethasone. Those people who don't suppress their cortisol release through feedback inhibition are the ones who tend to have the worst depressions, particularly psychotic depressions. Individuals suffering from psychotic depressions tend to be non-suppressors. It's about, at best, 80% specific and sensitive for depression, so we don't use it commonly. Although I'm sure you have and I have in very extreme cases of people who have severe strokes and can't communicate have used this kind of test sometimes. So, but the fact that people oversecrete cortisol and are in this chronic state of stress is what the dexamethasone suppression test is all about. The second, I think, interesting phenomenon that has been reproduced and we know a lot about and sort of proud about here at Hopkins because this is where it started. Nowadays, it's not a surprise to know that, if I told you that the brain was involved in depression, I don't think anybody participating in this would be particularly surprised. But actually going back to the 80s, people were absolutely shocked by this idea that the brain played a role. It was all sort of felt to be impacts on the mind and people's adjustment to life and melancholia and the like, but not a brain-based phenomenon. And so it was really work done here at Hopkins by Bob Robinson, leading the band, looking at post-stroke depression. And what was interesting about the post-stroke depression studies is that they showed, the important parts in choosing real estate, location. The interesting thing was that a frontal left-sided region involved in the stroke ended up being associated with a much higher rate of depression. And as you sort of wrap around the brain to the right side, it became less and less likely to have depression, all the way to the right frontal region, where there was actually a fairly high chance of having manias or disinhibition syndromes. So what was really surprising about that, I think, to most people is that the frontal left region, although involved in executive function and processing, is not a high real estate area in terms of having paralysis and sensory problems and speech problems. So that was sort of a surprising finding to many, that it actually ends up being the location. And nowadays, and perhaps we'll get to this later, much of the sort of modern electrical treatment, stimulation of the circuitry of the brain, reinforces the idea that location matters. For instance, those stimulatory treatments such as transcranial direct current stimulation or TMS and ECT have suggested that if you stimulate the left, because of course a stroke decreases activity, if you stimulate the left, particularly the left frontal region, and you inhibit the right frontal region, that tends to be a combination that tends to lift people's moods in a relatively rapid way, which fits with the earlier work done on post-stroke depression. And then finally, a set of studies that have been done, and again repeated extensively, are the monoamine depletion studies. And essentially, I find that these studies give the clinicians, we who practice treating patients, some firm ground to stand on. So although still the exact mechanisms of depression, we'll talk about some of the theories, are not definitively known, we do know that the medicines we use work the way we think they do. And the way we know that is from monoamine depletion studies, which is to say that if you take a patient who is depressed and you treat them, for instance, with an SSRI, a serotonin selective reuptake inhibitor, until they're completely in remission, and then you take that same individual while continuing their treatment, but you deplete serotonin from the brain. And that sounds painful, but it's actually fairly easy to do, which is you give them a tryptophan-free diet. Tryptophan is the building block for serotonin. Without tryptophan, the brain can't increase the levels of serotonin because it lacks the building block on which to synthesize serotonin. And what's interesting is those patients who are on SSRIs, 70 to 80% of them will flip into a depression again, because the SSRI is working through serotonin, and when you deprive serotonin from the brain, that no longer can work. And these SSRIs are sort of modern, more cleaner versions of the monoamine mechanism that we've known since the 50s. So we've known this for 60 years, that norepinephrine and serotonin have been involved in the treatment of depression. So that's reassuring. It also, by the way, is interesting to note that patients